Hello, and welcome to Statistics for Nursing. This is Chapter 4. I'm Dr. Elizabeth Heavey, and we are going to run through this chapter and make sure the content makes sense to you. So let's get started. Chapter 4 focuses on evaluating the actual measuring tools that you will be using. One of the things we have to consider when we look at our measuring tools and decide which ones we want to use is the feasibility of the tools in your study. First, we have to consider the practical aspects of the study's tool, such as how much is it going to cost? How much time is it going to take to implement? How much training will personnel need? And the limitations of your sample study. We need to make sure the tools we are going to use are actually practical or feasible. The validity of our tool is the accuracy, which is obviously a very important thing. We want the tool we select to accurately measure the variables. Sometimes it's also called construct validity because it means the tool was constructed or made accurately. You'll see on the left side here that when a tool is not valid, it's less accurate and it completely misses the main concept. The arrow didn't come close to the bullseye. To become more accurate, our tool gets closer to the bullseye as we move to the right. As we move on that continuum, our validity improves. There are different kinds of validity. Content validity is when the measurement tool includes the major elements relevant to the concept being measured. The relevant elements are determined from a literature review, and then the scale or tool has to be reviewed by experts in the field for completeness, conciseness, clarity, and readability. That is how you establish content validity. It's something the experts review and determine after the literature review. Convergent validity is established when you compare the results from a new instrument with an existing instrument that measures the same thing and has already been shown to be valid at that time with that population. If a correlation between these two instruments measuring the same thing is 0.4 or higher, it shows convergent validity and increases the accuracy in both of the instruments. Divergent validity is when a new instrument accurately measures an opposing concept from an existing validated instrument. Again, if your correlation in this case is greater than minus 0.4, it's a negative correlation because you're measuring the opposite, then the divergent validity of both measures is strengthened. For example, if a subject scores high on an existing validated instrument that assesses sadness, and your tool shows that same subject scoring low on a tool to assess joy, it improves the divergent validity of your tool. Validity from contrasting groups occurs when an instrument detects differences between the groups that are known to have a difference. For example, an instrument measuring internet usage in the generation of people that are 70 or older and the generation that's 15 or younger. If the tool is able to pick up on that difference, then you're starting to see validity established by contrasting groups. This can also be called construct validity testing using known groups. In this case, the elderly generation says, "When I was your age, being wireless was a claim only a trapeze artist would make." But clearly, the youngsters in the cartoon indicate that that's not how he perceives it. If the tool detects a difference in the understanding of wireless in the two age groups, it improves the validity or the accuracy of the tool. Validity can also be established from prediction of future or concurrent events. If the instrument can predict future events or results in another test at that time, it improves validity. If the score you get on one test is predictive of the score you get on another test or of the grade you will get in the future, then you will find that this is another way of establishing that it's an accurate measure. Reliability is an entirely different concept from validity. Reliability is simply repeatability. A measurement tool is reliable if it provides the same results each time a specific variable is measured. There are three different factors that we're going to talk about that can impact reliability: homogeneity, stability, and equivalence. You can see here on the bullseye that the location of the arrows hitting is far from the center of the bullseye. but they're almost all in the same place. That's a representation of a repeatable tool, but not an accurate tool. Reliability and validity are two different concepts. Homogeneity is the extent to which items on a multi-item instrument are consistent with one another. If you have questions that ask about the same concept that you're trying to measure, you should get about the same kind of answers on them. It determines the internal consistency of the two. It's usually measured with a Cronbach's alpha coefficient of a small r. The Cronbach alpha measures internal consistency on multi-item scales. If your R is 1, it's 100% reliable. If it's 0, there's no reliability in the measurement tool. Most of the time, if you're doing a study, you want the R value that's at least 0.8. The higher the value of the Cronbach's alpha, the better the internal consistency reliability. Stability is another factor in reliability. Stability is the consistency of the measure over time. You determine stability by testing and retesting with repeated measurements of a variable over a specific time period. The more stable that measure is, the more consistent it is over time, the greater reliability you have in your tool. Equivalence factors into reliability because it measures how well multiple forms or multiple users of an instrument produce the same results. One of the things we look for when trying to determine equivalence is inter-rater reliability. We assess inter-rater reliability if there is more than one researcher administering the same tool. If, for example, we have 3 nurses making observations, we want to make sure those nurses are categorizing the data in the same way. Assessing inter-rater reliability gives us that information. The readability of an instrument is also important because it affects the validity and the reliability of the instrument. Subjects have to be able to understand the words in your instrument in order to complete it accurately and consistently. I thought this was kind of a funny picture. The sign clearly says, "Do not chain bicycle to railing," and yet right next to it there's a bicycle chained to the railing. Now, perhaps the bike owner just didn't care, or it could be a situation where the person was not able to read the sign at the level it was written at. In that case, the person was not able to follow the directions and do what the sign writer wanted him or her to do. That is not what you want to happen when you're conducting a study. Remember, an instrument cannot be valid if it's not reliable. It can't be accurate if it's not repeatable. However, it can be reliable and not be valid. So if we look at the bullseyes on the bottom, I think it gives us a good visual for this idea. We'll see in the left corner an example of a reliable but not valid results. They are in the same area, but they're not near the bullseye. The second example shows us low validity and low reliability. They're not close to the accurate center, and they're not even close to each other. The third also shows us a situation where it's not reliable and not valid. Again, they're not close to the center and they're not close together. But the fourth one shows us a situation where the results are valid and reliable. They're close to the center, which means they're accurate, and they're repeatedly near the center, so they're reliable. An instrument has to be reliable and valid to measure a concept well. Also, remember, reliability and validity are not inherent attributes of an instrument. Just because we've established that an instrument is reliable and valid at one time and with one group, it doesn't mean that it will be with another. If we think back for a second to the instrument that worked well in our 15 and under crowd and found that it was reliable and valid, but as soon as we started asking our crowd over 70 about their use of wireless technology, we will find that that instrument is no longer reliable and valid measure because our older group doesn't understand the terminology in the same way as our younger group. We have to make sure that we assess the reliability and validity again if we are applying an instrument to a group where these have not been shown to be present. Now the next question we need to ask is, how do I know if the lab test I selected is a good one? There's several different features of any lab test to consider. These can be challenging for people to think about because most of us are used to thinking about test results as positive or negative, and that means you have the disease or you don't have the disease. But now you're statisticians and you're learning to think about it differently. You realize that there's actually at least four potential results to most tests, not just positive or negative. There's a true positive or a true negative, and a false positive or a false negative, because either positive or negative results could be an error. We want to make sure we understand the accuracy of a screening test. It's determined by its ability to correctly assess the presence or absence of a disease or condition. If the test is positive, what is the probability that the disease is present? If the test is negative, what is the probability that the disease is not present? Your test status and your disease status are actually two different things. These are the possible results when you have a positive or negative screening test. A true positive accurately identifies the presence of a disease. A false positive is where the test indicates the presence of a disease, but there is no actual disease. A true negative accurately identifies the lack of disease, and a false negative test indicates disease is not present when it actually is. This is where we're going to start building a 2x2 table. You will see our columns are labeled by disease status and our rows are labeled by test status. If the subject is in box A, he or she has the disease and tested positive. That's one of the results we would like to see. It's a true positive. But if the subject is in box B, unfortunately, he or she still tests positive but does not have the disease. That's an extremely stressful situation for someone to be in. If we go down to box C, you will see the subject tested negative, but he or she actually has the disease. Unfortunately, this could be someone who could be spreading the disease and not even know they have it. The true negative is box D. This is someone that doesn't have the disease, and luckily the test tells him or her that he or she doesn't have it. There are several measures that can come out of this 2x2 table. You're going to see that sensitivity is one of them. The probability that the patient will test positive for the disease if the patient has the disease. So this is going to take your true positives from box A and divide them by everyone that has the disease, which is box A plus C. A highly sensitive test is very good at identifying diseased patients and has a low percentage of false negatives. This is an important feature of a screening test, particularly if the disease is fatal, contagious, or if early treatment helps. If any of these conditions are in place, we want a highly sensitive test. Specificity balances with sensitivity. When one goes up, the other tends to go down. Specificity is the probability that the patient will test negative for the disease if the patient does not have the disease. Specificity is determined by taking all of your true negatives, which is box D, over all of those that don't have the disease, which is box B plus D. A highly specific test is very good at identifying patients without a disease and has a low percentage of false positives. You can see there's a very low percent of false positives in this highly specific test. The other things you're going to determine about a test is going to be the positive predictive value and the negative predictive value. It's easy to confuse these with sensitivity and specificity, so be careful. When you know the screening test results and you want to know the probability that the person has or doesn't have the disease, then you want to know the positive and negative predictability. We're going to step back for just a minute. When we're talking about sensitivity and specificity, you know the person has the disease and you want to know the chance that the test will be positive. With specificity, you know the person does not have the disease. What are the chances that the test is negative? If you know the person's disease state, then you're talking about sensitivity and specificity. When you're talking about predictive values, you know the test results, and you're saying what are the chances of the disease state being positive or negative. The positive predictive value is the subject's screening test is positive. What is the probability that he or she has the disease? For example, if your patient has a positive blood test, the patient may say to you, "Okay, well, this was a screening test. What are the chances that I really have the disease?" In that case, you would want to tell him or her the positive predictive value of the test. Remember, positive predictive value is calculated by taking your true positives, box A, over the total number that test positive. This is similar to sensitivity. Your numerators are the same, they're both box A, but when you're doing positive predictive value, your denominator changes. It's not those that are really sick, instead, it's all those who test positive. It's your test status that goes in the denominator for positive predictive value. Positive predictive value is impacted by prevalence. We're going to talk about that a little bit more. Prevalence is the amount of disease that is there. The more prevalent a disease is, the higher the positive predictive value on a test. Let's look at an example of positive predictive value. All of the babies born in New York State have a newborn screening test done. If a newborn screens positive for PKU, what are the chances that the newborn actually has PKU? That's something a new parent is going to want to know. You can tell the parent, your child is screened positive for PKU, but it turns out there's only a 1% chance that the baby actually has the disease. The positive predictive value in this case is very low. That's reassuring information that you can share with a parent. You can say, "We have to follow this up. It's important to do that. But there's also a very good chance that the baby does not have PKU, but we need to do more testing to be sure." Prevalence, that we just talked about a minute ago, is the number of existing cases or sick people in the population. It's a measure of disease burden. Populations that have a high prevalence of a disease are much more burdened by that disease than those who don't. The prevalence rate is determined by taking the number of cases over the total population and multiplying it by 100. When prevalence rates go up, there is a higher level of disease burden in that population. But why does prevalence impact positive predictive value? Think about this conceptually. If you apply a test to a population with low prevalence, like in our left box here, you're going to find a good number of people that are false positives. The low prevalence means the positives are less likely to be real positives. But if you apply the same test to a population with high prevalence, like our right box that you'll see, all these blue people are the ones that are really sick, there's a much higher amount of the disease, and in that case you will have fewer false positives, because in a high prevalence area the positives are more likely to be true positives. High prevalence increases positive predictive value, and low prevalence decreases positive predictive value. If you want to look at the math and how that actually works out, or you can just think about it in your head, when there's more of a disease, you're more likely to be able to trust a positive result that says someone has a disease. Whereas, if there's a very small amount of the disease, a positive result is more likely to be a false positive. Prevalence and positive predictive value move in the same direction. Negative predictive value is the opposite of positive predictive value. If a subject screening test is negative, then your negative predictive value tells you the probability that he or she doesn't have the disease. If a patient has a negative screen for a heart and stroke risk, and the patient wants to know, "What does this mean in terms of my heart and stroke risk? How likely is it that I'm not going to have a heart attack or stroke in the next year?" you can tell them the negative predictive value of the screen. So how does prevalence impact negative predictive value? Well, it's going to be the reverse of what we saw earlier. If you apply a test in a population that has low prevalence, such as our left box, remember the blue people are the people that have the disease, you're going to find a good number of true negatives. Low prevalence means the negatives are more likely to be true negatives. If you apply the same test to a population that has a high prevalence, which is our right box, you will have fewer true negatives, because high prevalence means the negatives are more likely to be false negatives. Low prevalence increases negative predictive value. High prevalence decreases negative predictive value. Prevalence and negative predictive value move in opposite directions. Efficiency is another thing we're going to look for when we're looking at our test. Efficiency is how many times the screening test and the actual clinical diagnosis agree. Efficiency is determined by adding the true positives and the true negatives and determining what proportion of your sample that is. Efficiency is the number of patients who are correctly identified by the test. Ultrasound can be used to screen for trisomy 21 or Down syndrome. The efficiency of the test tells us how many of the ultrasounds correctly identify fetuses that have Down syndrome and fetuses that do not have Down syndrome. You want a very efficient screen because false positives and false negatives both have significant implications for patients. So that's it. We've made it through Chapter 4. This is your time to go back and look at the Chapter 4 review questions in the book. The review exercises will also review content from the first 3 chapters. Keep practicing. It's going to start to make sense, I promise.